Namaste. I, Dr. Soumya Pahari, with the co-authors Dr. Saval Sapkota, Dr. Rupesh Ramtel, and Mitesh Kern, are going to present a case report abstract. It's titled Intracerebral Hemorrhage and Acute Subdural Hematoma Following Burr Drainage of Bilateral Chronic Subdural Hematoma. A case report and review of literature. Introduction. Chronic subdural hematomas are commonly encountered disease by the neurosurgeon. Its treatment with Burr drainage is relatively simple, safe, and effective with a low morbidity of around 0 to 9%. Recovery is good, however, unexpected deterioration may sometimes occur, which complicate the postoperative course. Numerous complications have been described, among which intracranial hemorrhage are considered as rare and devastating. It often carries a poor prognosis. Many mechanisms have been described for this complication, the most accepted one being that the hemisphere adjacent to the hematoma has a defective vascular autoregulation, which when combined with a sudden increase in the cerebral blood flow which occurs after evacuation of the hematoma, leads to the rupture of the vasculature and hence hemorrhage. We present a case of bilateral chronic subdural hematoma in an elderly male who developed intracranial hemorrhage and acute subdural hemorrhage following bilateral Burr drainage. Case presentation. A 69-year-old male presented to our department with complaints of persistent headaches and drowsiness for a month. He is a known case of diabetes mellitus since 5 years and is under medication. He is a non-smoker and consumes alcohol occasionally. There is no history of trauma or hypertension. On examination, the classical coma scale was of 12 by 15, with eye opening of 4, best verbal response of 3, and best motor response of 5. Rest of the physical examination were unremarkable. Baseline lab studies including coagulation profile, liver function test were within normal limits. On imaging, as shown in the figure, a non-contrast CT of the head at admission showed bilateral chronic subdural hematoma in the frontotemporal parietal region. After 8 hours following admission, the patient's GCS declined to 8 by 15 with E of 2, V of 2, and M of 4. Patient underwent bilateral Burr drainage under local anesthesia. Patient was placed in supine. Bilateral Burr holes were made consecutively. Stereotactic was performed on the left side first and on the right. Hematoma was washed in warm normal saline until the return was clear. Bilateral closed system subdural catheters were placed, and the patient's vital parameters remained stable throughout the surgery. In the immediate post-operative period, the patient improved with GCS of 14 by 15 with E4, V4, and M6. However, on the 8th post-operative hour, his GCS again deteriorated to 6 by 15 with E1, V1, and M4. Post-operative non-contrast CT of the head revealed intracranial hemorrhage on the left frontal region, left acute subdural hemorrhage, and left frontal pneumocephalus with significant shift of the midline. The patient was intubated and planned for another surgery. However, the patient's party refused it due to financial reasons. The patient passed away the following day. Clinical discussion. Though Burr drainage is a relatively simple procedure with low morbidity, its complications can include cerebral edema, tension pneumocephalus, recurrence of hematoma, subdural empyema, etc. However, intraparenchymal hemorrhage is considered rare in the literature. Hemorrhages occurring at distant site from the evacuation have been described, including the brainstem, which are even rarer. In bilateral chronic subdural hematoma, rapid and asymmetric decompression of the one side leads to sudden distortion of the midline structures, which results in the disruption of the vasculature and hemorrhage. The same might have been the explanation in our case, as no other risk factors like perioperative hypertension, preoperative contusions, or deranged coagulation were identified. Even M. Kruger et al. Have recently proposed a pathophysiological mechanism to explain the mechanism of hemorrhage which occurs after evacuation of such hematomas. The multifactorial reperfusion theory attributes it to altered cerebral blood flow and overdrainage of the cerebrospinal fluid. It has been suggested that twist drill craniotomy and closed system drainage allows slow decompression and can avoid the rapid dynamic intracranial change which are partly responsible for such hemorrhages. Furthermore, opening the dura in the first borehole to allow the subdural fluid to drain slowly before the second borehole is made also avoids a rapid shifting of the brain. A study by C.H. Pang et al. Revealed that drainage of fluid more than 400 ml was associated with increased risk of intracranial hemorrhage following borehole drainage. Hence, draining large amount of fluid should also be avoided. To conclude, intracerebral hemorrhages following chronic subdural hematoma evacuation is a rare and devastating complication. Its mechanisms are elusive. To prevent such complications, simultaneous drainage of bilateral chronic subdural hematoma should be done with a slow evacuation rate. These are my references. Thank you.
Good afternoon, my respected seniors and fellow colleagues. Today I, Dr. Farhin Pradhan, a medical officer in Dirgai Guru Hospital, is here to present my research on the topic trigeminal neuralgia, a study of pain improvement in patients after microvascular decompression. So let's begin. Trigeminal neuralgia, also known as tic douloureux, is a characteristic neuropathic pain described as sharp, sudden, unilateral, severe, shock-like, recurrent, and stabbing. The various factors that trigger the pain in trigeminal neuralgia are usually innocuous, such as brushing, chewing, swallowing, talking, smiling, and touching your face for any reason. The pain is limited to one or more branches of trigeminal nerve. As we all know, the three divisions of trigeminal nerve are ophthalmic, maxillary, and mandibular. In ophthalmic division, the pain will be commonly localized in supraorbital ridge. In maxillary division, the pain will be commonly localized in upper lip, ala, cheeks, and gums of upper jaw. In mandibular division, the pain will be commonly localized in lower lip, teeth, gums of lower jaw. The management consists of conservative and surgical management. In conservative management, carbamazepine are considered the first line of treatment, which falls under epileptic drug therapy, along with gabapentin, lamotrigine, and phenytoin. The non-epileptic therapy consists of baclofen. In surgical management, microvascular decompression is considered the most preferred procedure. The other procedures are gamma knife surgery and percutaneous procedures. Now, moving forward with our study, it is a retrospective study conducted in 37 patients diagnosed with trigeminal neuralgia who underwent microvascular decompression in Dirgai Guru Hospital. The duration of study is from November 2015 to June 2022. The outcome of pain was assessed by comparing the VAS score at initial presentation and after the surgery. Now, talking about the statistics, in this slide we can see the incidence of pain in male and female, in which female population were more affected, that is 59.40%. Talking about the incidence of pain in different age group, 55 to 65 age group were mostly affected, that is 37%, and the least affected age group was 76 to 85 of age group, that is 22.7%. Talking about the distribution of pain in divisions of trigeminal neuralgia, the combination of maxillary and mandibular division were most affected, that is 38.70%, and the least affected division was ophthalmic division, that is 6.45%, and right side was more commonly affected than the left side. Now, moving on to the VAS score comparison, VAS score observed at initial presentation shows that 50% patients were presented with a VAS score of 9, 11.7% presented with a VAS score of 10, and 35.2% presented with a VAS score of 8. After surgery, we observed a drastic change in VAS score, that is 86.4% presented with a VAS score 0, 10.8% presented with a VAS score 2, and 2.7% presented with a VAS score of 7. During their 12 months of follow-up, 97.2% presented with a VAS score 0, and 2.7% presented with a VAS score of 5. Now, looking at the bigger picture, 86.4% after undergoing microvascular decompression had complete relief of their symptoms, 13.5% had partial relief of their symptoms, along with recurrence seen in one patient and persistent pain seen in one patient. Following microvascular decompression, 75.7% of the patients had no complications. Pseudomeningocele was observed in 10.8%. Facial hypostasia was observed in 5.4%. Facial paralysis was observed in 5.4%. And hearing loss was observed in 2.7%. We also compared our study with two studies conducted in USA and China in 2018 and 2004 respectively. The data results of these two studies were similar to ours, which shows that after undergoing microvascular decompression, majority of patients had complete relief of their symptoms. Hence, our study shows that after undergoing microvascular decompression, most of our patients had complete symptomatic recovery with recurrence seen in one patient and persistent pain seen in one patient. Therefore, microvascular decompression can provide a successful outcome for pain improvement and thus is a gold standard for treatment of trigeminal neuralgia. Thank you.
So, good morning, everyone. I'm Dr. Prabhat Jha, and I'm MCS Neurosurgery resident at National Academy of Medical Sciences, Burr Hospital. And regarding this presentation, I'd like to share our experience with stereotactic biopsy of brain lesions. And this is an early experience at Burr Hospital. And I'd like to thank my mentors, especially Professor Rajiv Jha, for giving me this opportunity, and Nation for allowing me to present in this international conference. So starting my presentation, stereotaxy comes from the Greek word stereos, which means three-dimensional, and Latin taxis, meaning arrangement or order. And stereotactic surgery or stereotaxy is a minimally invasive form of surgical intervention. And it makes use of a three-dimensional coordinate system to locate interventions such as injection, stimulation, implantation, radiosurgery, etc. And it can be done either with a frame or frameless system, depending on the surgeon's preference and the location and size of the lesion. Regarding the background, it was initially developed by Horsley and Clark in 1906, and the first human use was done by Zweigel and Weisses in 1947. The frame-based stereotaxy became popular from 1940s, and there were different proliferation of stereotactic frames. And only in the late 1980s, the use of computer for the manipulation of MRI or CT data improved the accuracy of the MRI or CT scan, and use of 3D digitizers as pointing devices helped moving from frame-based to the frameless stereotaxy. Currently, at our center, we have a CRW, that means the Cosman Roberts-Wells stereotactic frame-based system. And the first frameless stereotactic system was used by David Roberts and associates in 1986. And regarding our experience with the frameless stereotaxy, the first case was performed in 2075, and till now 15 cases have been performed. And the basic sequences are: we confirm the diagnosis, we do a preoperative planning, then the stereotactic frame is attached to the patient in operation theater. CT HED is done with the frame attached to the patient, and then the CT data is entered into the software, and coordinates of the lesion are calculated, and point of entry is identified. The CRW frame is set up according to the coordinates calculated from the software. The position of the lesion is reconfirmed in a phantom frame. CRW frame is attached to the patient's head, and then the Burr hole and biopsy is done. So this is a picture showing the frame being attached to the patient, and following the attachment of this frame, we place an localizer on the patient's head and then do imaging. And the imaging is entered into the software, and as we can see the different points in the software, we can see the localizer position being represented by the dots, and these help us to localize the lesion, and then the coordinates of the lesions are calculated in the anterior posterior direction, the lateral direction, the vertical direction, the arc and the ring, and the slide is calculated. And following that, what we do is the patient is either placed in the Mayfield, either in the local anesthesia or under general anesthesia. But the general anesthesia can be difficult since the intubation can be difficult, as you can see in this patient. And following that, the CRW precision arc system is attached to the patient's head, and the coordinates calculated based on the software are used for setting up this device. And we can also confirm whether our coordinates are accurate or not by using this phantom base. And this base is on straddle, and the CRW system is straddle, so utmost care should be taken. And following that, what we do is we can see the patient's head, and then the frame has been attached. Then we are doing a Burr and biopsy, and this shows a needle going through the slide for taking a biopsy. Until now, we have done around 15 cases, and you can see that the first case we did was a female patient, 42-year patient, and then for her we did a left temporal lobe lesion biopsy, and the diagnosis was confirmed as WS grade 3, that is anaplastic astrocytoma. Then we had a negative case where we could only get a tiny fragment of glial tissue. Then we had a case of diffuse astrocytoma, and then we had a 26-year-old male where we could get only necrotic tissue. But as our experience improved with the technique, we could get consistent positive results, as can be seen as we got a case of frontal lobe mass in which we diagnosed it as a diffuse astrocytoma, then the thalamic mass we diagnosed as diffuse astrocytoma, then again the thalamic mass where we diagnosed it as a glioblastoma multiforme, then again a left thalamic mass where we diagnosed it as a glioblastoma. Then we had a lesion, most likely a fungal or tubercular granuloma, and the result came out to be positive as a tuberculoma. Then we had a case of basal ganglia biopsy where we could get a diagnosis of anaplastic astrocytoma. Then a left frontal mass was biopsied, and the diagnosis was glioblastoma multiforme. And a left parietal mass was also biopsied, and the diagnosis was glioblastoma multiforme. And the frontal mass was biopsied, and the diagnosis was glioblastoma multiforme. Then again, we had a thalamic mass, a corpus callosum mass, and the basal ganglia mass. So you can see that we did biopsy of most of the regions of the brain. Until now, we have around 2 cases of negative results. But since last 2 years, we have been consistently getting positive results only. Regarding discussion, so the mainstream substitute taxia precise tumor localization or the lesion localization, we have been able to do that using the software. And we want to decrease the surgery-related morbidity and improve the quality of surgery outcome. And it can be applied, as you can see, is for the tumor, as we have been doing. We have not started DVS, and it can also be used for spine or for radiosurgery, which we don't have, and for cerebrovascular diseases as well. And the major obstacles being high initial purchase, because since the instrument is high to purchase, and the maintenance cost is also high. The learning curve is somewhat, as for our experience, it was difficult initially, but now we have been doing it consistently, and we don't have to call the engineers and other staffs to help us, because we can do it independently ourselves, and we have been practicing it regularly. And then there are the cost of disposables as well. And the frame system, the basic advantage, I mean, like we have only done 15 cases till now, because we also have a neuro navigation system, the S7 Medtronic system. And because of that, we are not using the frame system regularly, because it is cumbersome for the patient to be attached to the frame and then take him or her for CT. And it has to be attached ideally for somewhere close to 2 to 3 hours. So that's quite cumbersome. So that's why our case number are not that high. But the major limitation, as I've said, is the bulky assembly limits the head positioning, physical interferes with the performing a craniotomy, and the arc assembly for aiming is non-intuitive, non-interactive, and limited to a single trajectory at a time, and which can be improved with the frameless system. So which we are using more commonly. But consequently, frame system tend to be reserved for procedures such as needle biopsy, because it's the best system for performing a biopsy, because the accuracy is somewhat better than the frameless system. And the success rate for obtaining a definitive diagnosis is more than 95%, but depends on the type of pathology as well. Because if the lesion is cystic, then there is high chances of a negative result. And in general, the diagnostic success rate is highest for tumor cases. And the contraindications, as is obvious, is for very small lesions and for coagulopathic patients. And the major risks that are encountered are bleeding, infection, and seizure. But till now, we have not encountered any cases with major complications in our series. And so, concluding my presentation, frame-based stereotactic brain biopsy is a safe and effective procedure for diagnosis of different brain lesions in our setup. And the accuracy will increase and the learning curve will decrease with further experience. And so till now we have done 15 cases, and hopefully we'll be able to do more. And hopefully we'll be able to apply this system for performing other major procedures such as DBS or for any epilepsy surgery in the future. So that's our basic plan. So I'd like to thank you again for listening to me.
A very warm welcome and hello to all the respected seniors and my beloved colleagues. I am Dr. Shramad Gurung, currently working as a medical officer at Dirgai Guru Hospital, situated at Chaba Hill, Mitra Park. This is a short presentation based on our research, which is titled as Alleviation of Pain in a Week, a Month, and in 3 months after a minimally invasive open lumbar discectomy in indicated cases of prolapsed intervertebral disc presenting with low back pain and radiculopathy. So before starting on with this presentation, I'd like to thank our respected Professor Dr. Gopal Raman Sarma sir for providing us with his constant guidance and his valuable support throughout the completion of this research. I'd also like to thank our respected Dr. Alok Dio sir for giving us an opportunity to conduct this research. And lastly, I'd like to thank my research partner, Dr. Ria Shrestha, without whose help this research would not have been possible at all. So these are the headings under which I'll be briefly talking about throughout this presentation. We have introduction, aims and objectives, materials and methods, results, and conclusion. So low back pain has emerged as one of the most important public health issues with a lifetime prevalence as high as 84%. It is mainly associated with population involved in heavy lifting, twisting, or traumatic events, with 52 to 60% being work-related. A common ailment associated with lower back pain and radicular leg pain is a lumbar disc herniation, which occurs when the nucleus pulposus or annulus fibrosus of the disc protrudes outside the intervertebral disc space. So this is a diagram showing a prolapsed intervertebral disc and how it is compressing on a spinal nerve root, which produces symptoms such as lower back pain or radiculopathy. So the primary features and symptoms of lumbar disc herniation are radicular leg discomfort, sensory abnormalities, and weakening in the region of one or more lumbosacral nerve roots. Additional symptoms include focal paresis, restricted trunk flexion, and an increase in pain while straining, coughing, and sneezing. So the treatment methods include conventional treatments such as physical therapy, which includes core strengthening exercises, back muscle strengthening exercises, joint mobility exercises, or a patient can opt out for a corticosteroid injections, which helps in reducing the inflammation of the area. And we have operative treatment, under which we have minimally invasive open lumbar discectomy and transforaminal endoscopic lumbar discectomy. Compared to conventional treatment methods, surgical approach is more effective in cases with resistance or localized deficit. Minimally invasive open lumbar discectomy, or MIOLD, is the gold standard treatment for symptomatic individuals who need surgery for a lumbar disc herniation, producing radiculopathy that has not improved with conservative treatment. The minimally invasive open lumbar discectomy is preferable over other surgical approaches, as the success rate following surgery has been found to be high, ranging from 50 to 98%. In our country also, we mostly advise patient to go through MIOLD, or minimally invasive open lumbar discectomy, if the patient has failed to produce any relief in symptoms through conventional treatment methods. So, talking about the aims and objectives of my research, it is solely to study the improvement of low back pain and radiculopathy after 1 week, 1 month, and 3 months follow-up in indicated cases of prolapsed intervertebral disc after minimally invasive open lumbar discectomy. So, materials and methods.
It is a retrospective clinical study of 260 consecutive patients who underwent minimally invasive open lumbar discectomy. The duration of study is from November 2015 AD to November 2021 AD, conducted at the Guru Hospital, Kathmandu. The clinical outcome is assessed using a visual analog score, or VAS. All data were analyzed using Microsoft Excel 2021. The comparison between preoperative and postoperative measurements is done using paired t-test and considered significant if the p-value is less than 0.05. So these are the results that we obtained throughout our research. Among 260 cases, 59.81% were male and 43.40% were female. 53.80% of the cases presented with lower back pain. 8.07% is presented with radiculopathy, whereas 38.07% is presented with both radiculopathy as well as lower back pain. So the severity of pain, as we can see, 54.20% had severe pain, whereas 45.70% had moderate pain before the surgery. So this is a chart showing post-surgical improvement of pain. So as we can see, after 1 week, around 94% of total cases had the pain relief, whereas around 97% had a pain relief after 1 month, and the remaining and about 98% had pain relief after 3 months. So, talking about the post-operative complications, 7.30% had CSF leakage during the first week of post-operative period, whereas 1.50% had dysitis after 1 month of post-operative period. So, as conclusion, among total number of cases studied, most of the cases achieved a significant pain relief within a week, and only a few cases needed approximately 1 to 3 months for the symptoms to be relieved, and hence, minimally invasive open lumbar disectomy provided significant pain relief in patients who initially presented with low back pain and neck pain. Thank you.
Namaskar and greeting of the day, everyone. My name is Kalpana Thapa, currently working in TUTS Hospital in Operation Theatre as a registered nurse, and it is great honor to be here today. Now, I'll be talking about ensuring safe neurosurgery, re-emphasis on utilization of safety checklist. And my contents are introduction of surgical safety checklist and importance of using surgical safety checklist, some components of surgical safety checklist, and some limitations of using safety checklist. And let's move into the introduction of surgical safety checklist. Surgical safety checklist is patient safety communication tool that is used by a team of operating room professionals like surgeons, circulatory and scope nurses, anesthesiologist, and anesthesia assistant. Surgical safety checklist was initiated by WHO in 2008. And this is the surgical safety checklist initiated by WHO. And let's talk about some importance of using surgical safety checklist. It is very essential because it helps to increase the detection of potential hazards, as we discussed about the operation procedure with the entire team just before starting surgery. So it is very helpful, and it also helps to decrease the surgical complications, as we always assure about giving prophylaxis antibiotic, which helps to minimize the surgical site infection, and it is also helps to increase the communication among OT staff, as we discuss about everyone's role in the surgical safety checklist, and it helps to enhance the patient's safety by prevent never events such as a wrong site and procedure, because we always make sure that the right surgical site mark has been done or not. Likewise, it helps to be aware of some mishappenings like forget to give prophylaxis antibiotic and missing counts like needles, spons, and cottonoids in the sign-out session. And let's talk about the components. There are 3 main components of surgical safety checklist. They are sign in, time out, and sign out. In the first step of the surgical safety checklist, we just perform the signing activity, which is conducted before the induction of the anesthesia to the patient. In this session, the patient is confirmed along with the identification like name, age, and hospital number, and surgical site, procedure, and the consent of the patient. And we just verify the any known allergy to the patient, and the verification of difficult airway, aspiration risks, and if there is the risk of blood loss more than 500 ml, and adequate IV access and fluid plan can be made. And in the timeout session, it is done before skin incision with all operating team member. In this timeout session, we just confirm loudly just before giving the skin incision to the patient. We just verbalize the patient's name, surname, and the date of birth, and the surgical and invasive procedure site, and the what is the procedure to be performed by the surgeons. Likewise, surgeons provides information about how long will the case take and anticipated blood loss to the entire team. It helps to be prepared all of the involved staff members to prepare by themselves and to perform their activity. And surgeons provide information regarding critical or non-routine steps which can be performed during the surgery. Likewise, anesthetist provides information regarding any specific concerns during surgery, and the nurses should confirm the sterility of equipments and any equipment issue just before starting surgery. And in the timeout session, we also confirm the imaging has been displayed or not, whole entire OT. And we should confirm whether the antibiotic prophylaxis has been given or not within last 60 minutes. And in the third session, sign-off session, which is done before patient leaves the operating room. And in this session, nurse verbally confirms the specimen preservation and its labeling properly. And we should confirm whether there are any equipment issue problem to be addressed or not. And all team members confirms the key concern for recovery and management of the patient. There was the study conducted regarding surgical safety checklist on the topic of awareness and knowledge of the surgical safety checklist among healthcare professionals in University Hospital, Kathmandu, Nepal. In this study, cross-sectional study conducted among the healthcare professionals in TUTS, and it was published on the Kathmandu University Medical Journal in 2021. And the findings were 92.9% had been aware of WHO surgical safety checklist, and 67.9% were unable to use safety checklist due to lacking appropriate training, and 50.9% staffs had unwillingness to use safety checklist, and 39.7% staff had lack of experience how to use surgical safety checklist. But it is the current adherence of using surgical safety checklist, especially in the neurosurgery. Total neurosurgery cases operated in TUTS OR from March to August 2022 within 6 months. Major routine cases were 210, and we were able to perform the surgical safety checklist in all of those 210 routine cases, 100%. But in the major case, in the ER case, there were 116 total ER cases conducted in the neurosurgery, and we were able to conduct the surgical safety checklist in total 90 cases, which is 77.5%. Because some of junior surgeons are still not really aware of using surgical safety checklist, but still we are trying to improve. Okay, so some limitations of using surgical safety checklist are lack of commitment towards the initiation of WHO safety checklist by the operation team during the earlier phase, and it's quite time consuming if there is a very emergency situation, and sometimes it is inappropriate timing to perform all of those three component of the activity, and it is unaccounted risks. For example, surgical safety checklist doesn't cover about the skin preparation and post-operative management, especially pain management and vomiting. And there are some important points to be remembered. Every check can save your and the patient's life, because even the single mishap can ruin the patient's life and the healthcare team's life. So we must remember that. And this checklist is a document, but also a material for operating rooms that helps us to be safe for our work and save our patients. That's why it is very essential. And this is the video of how we conduct timeout session in our operation theater due to SOT. This is how we must be sure before starting surgery. Thank you.
Respected professors, my seniors, colleague, and my dear friend, I am Dr. Arju Kharka, and I'm working as a medical officer in Dirgayu Guru Hospital, Kathmandu. I am going to present on the topic outcome analysis of anterior cervical discectomy and fusion surgery, which was analyzed by Dr. Mahima Sitola, myself, Dr. Arju Kharka, Dr. Alok Dio, and Professor Dr. Gopal Raman Sarma. The study was conducted in Dirgayu Guru Hospital, Travel, Kathmandu. Before going into the topic proper, let me explain a little about anterior cervical disc prolapse. It is a condition in which the gelatinous substance of the disc escapes through a tear in the outer fibrous ring, which causes the compression of the spinal cord or the surrounding nerve, resulting in the symptoms such as pain, tingling sensation, numbness, and others. Patients usually present with radicular pain, myelopathic pain, or combination of both. Majority of the cases are due to degenerative changes, followed by trauma and infection. The diagnosis of anterior cervical disc prolapse is usually clinical through patient's history and physical examination. However, CT scan and MRI can be used to confirm the diagnosis. For this condition, initially, we go for a conservative management, which includes analgesic, muscle relaxant, physiotherapy, and steroid injection. For those cases whose symptoms does not improve with conservative management or gets worse, surgery can be considered. There are two approaches, anterior and posterior, for cervical discectomy and fusion. Among them, the anterior is usually preferred. Anterior cervical discectomy and fusion surgery is a minimally invasive procedure, which includes removal of the herniated disc from between the two vertebrae. And after the removal of the disc, the vertebrae are fused together by autograft or allograft. Coming back to the study, the purpose of our study was to analyze the outcome of anterior cervical discectomy and fusion surgery. It was also to study the condition of patients before and after the procedure according to the Neuric classification. The post-procedure complications were also to be analyzed in the study. The neuro classification is a grading system devised primarily to assess ambulatory status of the patient and reflects its effect on employment. It is categorized from grade 0 to grade 5, where grade 0 represents root involvement, but no evidence of spinal cord disease. On the other hand, grade 5 in the neuro classification represents chair-bound or bedridden status. The study we performed in the Guru Hospital involved 50 cases who underwent anterior cervical disectomy and fusion surgery from the year 2016 to year 2021. The type of this study was retrospective in nature. Out of all the cases studied during this period, 72% of the cases were male and the rest 28% were female. In the ASDH surgeries that were performed during this period, the autograft and allograft were equally used for fusion. In our center, the iliac crest bone graft was used for autograft and polyether ether ketone was used in the allograft. The result of our study showed that degenerative changes was the major cause and was found in 74% of cases. It was followed by traumatic and infectious causes, which were seen in 24% and 2% of cases respectively. Let us look at the chart that demonstrates the neuro classification before and after the ASDH surgery. Initially, there were just 3 patients in grade 0, 22 in grade 1, 9 in grade 2, 4 in grade 3, 4 in grade 4, and 8 patients in grade 5. After the procedure, it was observed that the surgery had a positive impact on all the patients, and the majority of the patients were classified as grade 0. Regarding the complications which occurred up to 7 days following the surgery, it was found that 82% of the cases had no complication at all. Among the observed complications, 8% of the cases had CSF leak, 6% had surgical wound site infection, and 4% of the cases demonstrated dysphagia. Following the complication, there was 6% of mortality, in which infection and sepsis were the leading cause. From this study, which we performed in Guru Hospital, we have concluded that when anterior cervical disc prolapse requires a surgical intervention, the ASDH surgery is a very impactful procedure for treatment. We would like to thank everyone who were directly or indirectly involved in the study, and also would like to thank Nepalese Society of Neurosurgeons for providing us a platform to discuss about our study. Thank you and have a great time.
Good afternoon, respected seniors and dear colleagues. I, Dr. Sushil Pandit from Guru Hospital, today is going to present on my topic of review of tumor excision in Guru Hospital. Tumor excision. Brain tumor is a growth of cells in the brain that multiplies in abnormal, uncontrollable way. Excision is the removal of tissue from the body using a scalpel, laser, or other cutting tool. A surgical excision is usually done to remove a lump or other suspicious growth. So normal tissue around the growth is usually removed at the same time. History. On November 25, 1884, Mr. Rickman J. Goldie performed the first recognized resection of a primary brain tumor. The original patient of Mr. Goldie died on 28th postoperative day of apparent meningitis and secondary complication. Indication of tumor excision in neurosurgery. The first treatment for brain tumor is often surgery. The goal of brain tumor surgery is to remove as much of the tumor as possible without causing harm to the normal tissue. Surgery can also provide an opportunity to biopsy the tumor to learn more about what type it is and whether it's cancerous or not. Ethical consideration. Neurosurgeons alone have the training and education to operate an organ that constitutes the locus of humankind consciousness, emotion, and intelligence. The ethical dilemmas inherent in acting upon the nervous system have long been apparent, involving the challenge of manipulating the anatomical locus of human identity. This graph shows the total number of our cases and complications after the tumor excision. According to our experience, total number of patients undergoing tumor excision is 225 in our hospital during the study period of 7 years. Of the total tumor excision, majority were female, 67.1%, with mean age of 43.9 years. Majority of cases were meningioma, followed by pituitary adenoma. Pre-operative workup done in our center includes history, physiological assessment, complete neurological examination, imaging CT scan and MRI, pre-anesthetic checkup, complete blood count, coagulation profile, and informed consent. We observed that out of the total cases who underwent tumor excision, only 7% had outcome of Glasgow outcome score less than 2. Most frequent complication seen is diabetes insipidus after excision of pituitary adenomas. 20.4% cases develop diabetes insipidus. No complication is seen after excision of oligodendrogliomas, which constitute 5.7% of the case. Postoperative management, imaging CT or MRI the next day, analgesics, antibiotics, intravenous fluid until tolerated orally, closed ICU observation. Risk factor for the complication include age over the 75 years, sex female more than male, preoperative symptoms, MRI findings, tumor location, nerve of origin, chronic illness, and diabetes. Complications. Even though neurological tumor excision decreases overall mortality and morbidity, it is associated with complications such as immediate trauma to the airway, seizure, intracranial hemorrhage, damage to the nearby nerval brain tissue. Early complications include brain edema, elevated intracranial pressure, failure to wean from mechanical ventilation, ischemic infarction, need for reoperation, and cerebrospinal fluid leakage. Late complications are motor deficit, meningitis, deep vein thrombosis, pulmonary edema, and ventilator-associated pneumonia. Results: 27.55% of the patients who underwent tumor excision in our center developed postoperative complications. Common complications we tackle include seizure, elevated intracranial pressure, diabetes insipidus, cerebrospinal fluid leakage, failure to wean from mechanical ventilation, meningitis, cranial nerve palsy, and visual impairment. This graph shows total number of the complications in our center. This graph shows total number of cases and complications after the excision of tumor. Results: meningioma. 20.8% of the cases are meningioma with complication of 19.3%. Raised intracranial pressure and seizure being the majority ones. Astrocytoma. 14.2% of cases were astrocytoma with complication of 16.2%. Raised intracranial pressure and seizure being the majority ones. Schwannoma. 7.5% of the cases were schwannomas with complication of 4.8%. Cranial lobe palsy and raised intracranial pressure, along with seizure and CSF leakage, were the complications seen in the patient after the excision of schwannomas. 20.4% of the total cases were pituitary adenomas, with complication of 24.2%. All the patients who underwent excision of pituitary adenomas developed diabetes insipidus. Medulloblastoma, 7.2% of total cases, with complication of 6.4%. Seizure, hydrocephalus, and raised intracranial pressure being the complication after the excision. Oligodendrogliomas, 5.7% of total cases with no immediate complications. Glioblastoma, 18.7% of total cases were glioblastoma with complication of 19.4%. Increased intracranial pressure and seizure being the major complications. Craniopharyngioma, 5.4% of total cases were craniopharyngioma with complication of 9.7%. Seizure, raised ICP, and CSF leak being the complications. Mortality, 7% had outcome of Glasgow outcome score less than 2, with 3% who had in-hospital mortality. Mortality of this patient can be attributed to the patient's primary condition and complication after surgery, not to the procedure itself. In conclusion, tumor excision in neurosurgery is associated with improved survival and reduced likelihood of local tumor. Modern neurosurgery is generally fairly safe, but serious complications can always occur with proper care and treatment. We can reduce the risks associated with surgery and decrease morbidity and mortality. Thank you.
Good afternoon, everyone. I'm Dr. Nikhil Gongal, one of the medical officers working in Gurung Hospital, and I'm here to present my research topic, which is incidence of diabetes insipidus as a complication in surgery of pituitary macroadenoma in a tertiary neurosurgery hospital of Nepal. So as we all know that pituitary adenomas are abnormal growth that occurs in the epithelial cells of pituitary gland, and the tumors that are more than 10 millimeters are known as macroadenomas, and those that are less than 10 millimeters are known as microadenomas. The patients may come with various symptoms such as headache, visual disturbance, weight gain, change in bone structure, menstrual irregularities, lactation, and erectile dysfunction. So the mainstay treatment for pituitary macroadenoma is surgery. However, various other modalities of treatment like medical treatment with dopaminergic agonists such as bromocriptine and cabergoline and also radiotherapy can be used along with surgery, which might help in reducing the size of the tumor and also help with the hormonal imbalances. So the surgery can be done by two approaches. One is transperineal approach, which can be done using a microscope or an endoscope, and the next is a transcranial approach. So the complications following pituitary surgery can be due to pituitary hormone insufficiency, such as central diabetes insipidus, hypothyroidism, and hypogonadism. And other complications include CSF leakage, epistaxis, meningitis, and visual impairment. So talking about diabetes insipidus is the passage of large volume of dilute urine, which is more than 3 liters per day of less than 300 milliosmol per kg of urine. And it can be broadly classified into mainly two types, which is central or neurogenic or pituitary or hypophyseal diabetes insipidus. And also the next is nephrogenic diabetes insipidus. Some other forms of diabetes insipidus are gestational diabetes insipidus and primary polydipsia, which is also known as dipsogenic diabetes insipidus. So talking about central diabetes insipidus is associated with deficiency of secretion of ADH hormone from the pituitary gland. It can occur due to various reasons, such as it can be idiopathic or due to malignant or benign tumors of the brain, cranial surgery, or also in cases of head traumas. So what causes diabetes insipidus is there is deficiency of ADH due to any of the previous causes, which leads to decrease in permeability of water in the collecting ducts of kidney, and this causes excretion of large volume of dilute urine, which in turn leads to increase in plasma osmolality and decrease in urine specific gravity. In case of conscious patients, thirst mechanism is activated and which stimulate polydipsia. However, if there is decrease in fluid ingestion in response to increased thirst leads to hypernatremia and ultimately to dehydration. So the postoperative diabetes insipidus can be graded into three types. One is transient diabetes insipidus, which occurs after surgery and usually resolves within 2 weeks of surgery. The second is prolonged diabetes insipidus, which occurs after the surgery and usually persists even after 2 weeks, however, gets resolved within 6 months. The third is chronic or persisting diabetes insipidus, which persists even after 6 months of surgery. Now, how do we diagnose postoperative diabetes insipidus? So the diagnosis of postoperative diabetes insipidus is based on the presence of hypotonic polyuria, which is less than 300 milliosmol per kg and more than 2 ml per kg per hour of urine, along with an increase in plasma osmolality, which is more than 300 milliosmol per kg. And it is very important to also rule out any other causes of polyuria, such as glycosuria, mannitol administration, or renal failures. So in case a patient is suspected of having postoperative diabetes insipidus, the patient's 24-hour urine sample is collected and the urine volume is determined. Along with urine volume, it is also important to measure the patient's serum electrolytes and glucose level, urine specific gravity, plasma and urine osmolality, plasma antidiuretic hormone, and in some cases, water deprivation test is useful to differentiate between neurogenic and nephrogenic diabetes insipidus. So the treatment of diabetes insipidus is with desmopressin, which must be accompanied by sufficient fluid intake in order to prevent dehydration and maintain the fluid balance. So coming to our study, the purpose of our study was to find the incidence of postoperative diabetes insipidus following microscopic transsphenoidal pituitary macroadenoma surgery in the Gurung Hospital and to know the factors affecting it. So the prospective study includes postoperative records of 46 patients who had undergone microscopic transsphenoidal resection at Dirgai Guru Hospital between May 2014 and July 2022. The diagnosis of diabetes insipidus was made by analyzing the urine output, urine osmolality, urine specific gravity, and serum sodium levels in the patients and excluding any other causes of polyuria. So what we found out was the total number of pituitary macroadenoma cases that underwent surgery was 46, among which 47.82% were male and 52.17% were female. Now, the overall incidence of postoperative diabetes insipidus was found to be 32.6%, which is 15 patients among the 46 patients developed diabetes insipidus. Now, the incidence of postoperative diabetes insipidus according to gender revealed that females were more prone to developing diabetes insipidus than men, which was 60% in female and 40% in men. Now, the incidence of postoperative diabetes insipidus according to its types suggested that the maximum number of cases developed transient diabetes insipidus, which was 80% of cases, and the remaining 20% developed prolonged diabetes insipidus. However, no patients developed chronic diabetes insipidus. Now, the incidence of postoperative diabetes insipidus according to age group revealed that the maximum number of cases of diabetes insipidus was found in the age group of 31 to 40 years, which was 46.67%, which was followed by 41 to 50 years of age group, which was 33.33%. Now, comparing our data with the world data, the research done in University of Bonn, Germany on September 2009 and Zhejiang University in China in May 2022 revealed that the incidence of postoperative diabetes insipidus following microscopic transsphenoidal surgery was 38.5% and 38.08% respectively, compared to Dirgai Guru Hospital, which was 32.6%. Another research that was done in BSMMU Bangladesh on July 2017 suggested that the maximum number of cases of diabetes insipidus after microscopic surgery was seen in patients with more than 30 years of age group, which was consistent with that of our study. And also, it was suggested that female were more prone to developing diabetes insipidus than men, which was also consistent with our study. Now, the conclusion of our study shows that less than half of the pituitary adenoma patient who underwent microscopic transsphenoidal surgery developed diabetes insipidus as a complication, with most of the cases being transitional diabetes insipidus, and the females were more prone to developing diabetes insipidus as a complication than men, and most of the patients were between the age group of 30 to 40 years. Therefore, such patients with pituitary adenoma had a higher risk of developing post-surgery diabetes insipidus and thus need to be carefully monitored during and after surgery. Thank you.
With a warm welcome and good morning to all. I, Dr. Samreda Malla, FCPS Neurosurgery Resident at Annapurna Neurological Institute, would like to begin my topic. My topic is the clinical predictors of CSF diversion in posterior fossa tumors, a retrospective study. So I would begin with the introduction and followed by the objective methods of the study, results, conclusion, and followed following the discussion. I have no any disclosures. So to begin with, posterior fossa tumors are the most common CNS neoplasms seen in children, whereas these tumors are also common in adults, in which hydrocephalus is found in almost 40% of the cases. And hydrocephalus is primarily due to the proximity of the tumors within the fourth ventricle and the cerebrospinal fluid pathways. So a proportion of these patients will require CSF diversion at some time during the course of treatment. However, no any consensus exists regarding the management of hydrocephalus before, during, and after the surgery. Prophylactic treatment of ETB has been reported to reduce the risk of hydrocephalus post-tumor resection. However, treating all the patients in this manner can potentially expose the patient to unnecessary procedures. So the main objective of the study is to present the results of the surgery for posterior fossa tumors with or without CSF diversion and describe the patients who may require a permanent CSF diversion post-operatively. A retrospective analysis of the patients with posterior fossa tumors admitted at Annapurna Neuro Institute from January 2020 to July 2022 was done, and patients who underwent surgical management through a suboccipital craniotomy or craniectomy or a retromastoid retrosegment approach with or without CSF diversion were evaluated. Demographic, clinical, and radiological data were extracted from the in-hospital records via medical record health system, and the radiological data was analyzed with either a CT scan or an MRI scan obtained both pre and post-operatively. The diagnostic criteria for the preoperative hydrocephalus were set with the Evans index, which is the maximum width between the frontal horns divided by the maximum width of the inner table, that is the biparietal diameter of more than 0.3, with signs of intracranial hypertension such as headache, nausea, visual disturbance. The follow-up data were obtained from the last outpatient consultation or via telephone calls. Follow-up duration ranged from 6 months to 2 years, and the information that were recorded were patient characteristics, preoperative hydrocephalus, surgical procedure and extent of surgical resection, tumor histology and location, perioperative placement of EVD and or VP shunt, and postoperative complications. So the prophylactic EVD was defined as the intraoperative placement of EVD once considered after discussion by the surgeons on the case, but in our case, no any preoperative EVD placement was done. The criteria for postoperative EVD placement was an Evans index of more than 0.3 with symptomatic intracranial hypertension. The time for EVD insertion to removal was less than 12 days in all the cases, and the criteria for the removal of the drain was stable patient while increasing the drainage height and closing of the drain for at least 12 to 24 hours with no evidence of hydrocephalus on the consequent CT images. And the criteria for postoperative VP shunt placement was failed EVD weaning or symptomatic persistent hydrocephalus necessitating permanent drainage. Regarding the extent of resection, total resection was defined as no residual tumor after dissection following a postoperative CT scan and an MRI scan. The degree of hydrocephalus was categorized as mild, moderate, and severe with the Evans ratio, mild being 0.3 to 0.34, moderate being 0.35 to 0.4, and severe being more than 0.4. And the exclusion criteria of this study was patients who did not receive a tumor excision, post-op mortality, and posterior fossa pathology other than tumors. So the statistical analysis were performed using IBM's SPSS statistics version 20. Parameters were compared between groups using a student's t-test, and binary parameters were analyzed by a chi-square test. Multivariate logistic regression analysis were performed to identify independent predictors of the EVD placement. Odds ratio and 95% confidence intervals were calculated to assess the impacts of the variables, and a p-value of less than 0.05 was considered statistically significant. So to discuss with the results, among the 42 patients enrolled, 38 patients were included and 4 patients excluded in accordance with the exclusion criteria, which were that the 1 patient did not receive surgical resection, 2 patients had post-operative mortality, and 1 patient presented with cerebral AVM. So the mean age of the patient was 29.5 years, is ranging from 3 to 64 years. Most of them were male, that is 53%, and female were 18, that is 47%. The most common chief complaint presenting to us was headache, followed by diminished hearing in cases of vestibular schwannomas, followed by ataxia or gait imbalance, blurred vision, facial palsies, and other complaints. So regarding the degree of hydrocephalus, all of the cases of the preoperative hydrocephalus presenting to us were below the age of 18 years of age, which were mild. 4 cases were mild, 5 cases were moderate, and just 1 case was severe. Regarding the extent of resection, a gross total resection was achieved in 79% of the cases, whereas a subtotal were received in 21% of the cases. Regarding the tumor histology or pathology, the most common pathology presented to us was a schwannoma, that is 34%, followed by ependymoma, followed by a medulloblastoma and meningioma at 16%, and also we had a few cases of epidermal cyst, astrocytoma, and 1 case is of hemangioblastoma and arachnoid cyst. So regarding the CSF diversion, most of the patients, that is 49% of the patients, did not require any form of CSF diversion procedures, whereas 39%, that is 13 patients, required a perioperative EVD, and 12%, that is 5 patients, required a postoperative VP shunt. And among the patients who had a perioperative EVD, just 7%, that is 3 patients, only required a postoperative VP shunt. The most common complications presented to us were the pseudomeningocele, followed by hydrocephalus, facial palsy, infection, which is meningitis, and 1 case of recurrence. So the analysis of clinical predictors to predict the predictors of post-operative hydrocephalus, in the total, a total of 23, that is 60.5%, had benign tumors, whereas 15, 29.5% had malignant. 3 out of 10 patients with preoperative hydrocephalus received a postoperative VP shunt, whereas 2 patients required a VP shunt after development of a postoperative persistent hydrocephalus. The mean EVD time implantation was 2.4 days. The rate of the preoperative hydrocephalus was highest in patients with medulloblastomas and ependymomas. The univariate analysis showed that the postoperative EVD due to acute hydrocephalus was significantly correlated with tumor growth characteristics, resection degree, and postoperative infection, whereas postoperative hemorrhage and subtotal resection were identified as independent risk factors. So regarding the postoperative VP shunt, overall just 5, that is 13.1 patients, received a postoperative VP shunt placement, including 3 who had initially received the perioperative EVD. A univariate analysis showed that the postoperative VP shunt placement was significantly correlated with tumor pathology, preoperative hydrocephalus, and postoperative infection, whereas tumor infiltrating the ventricular system and postoperative hemorrhage were independent risk factors. This is the univariate and multivariate analysis that was done. So to discuss with, the postoperative symptomatic hydrocephalus is a severe complication which can occur after resection of postoperative tumors. However, no any consensus remains in the placement of prophylactic EVD or ETV. The ratio of preoperative hydrocephalus is much more higher in pediatric population, as seen also in our case series. The incidence of preoperative hydrocephalus in our series was 26%, and the incidence of persistent postoperative hydrocephalus was 13%. The highest proportion of the postoperative tumors in our case were schwannomas, followed by ependymomas and medulloblastomas. Also, multiple studies and review of literature have shown that these tumors rank in the top in terms of morbidity. So symptoms of intracranial hypertension can be resolved in most adult patients. So therefore, CSF diversion is not routinely recommended in adult patients. Some studies have also shown that incident postoperative hydrocephalus is higher in tumor located near the midline. Some studies, that is Chen et al., analyzed the fourth ventricle tumors and considered that the upward growth of tumors as an independent risk factor for post-op CSF drainage. One et al. Said that the patient in semi-sitting position could reduce the incidence of post-operative hydrocephalus by improving the outflow of the blood and protein-rich CSF during the surgery. So tumors with unclear margins and reduced blood supply are more difficult to resect because they can cause post-operative hemorrhage. So in our study, total resection was an independent protective factor for the postoperative acute hydrocephalus. So while we also may favor preoperative EVD or ETV, there is a retrograde herniation may pose a problem in some cases. So a few of our cases, these are 2 cases of medulloblastoma in children that we performed with the postoperative CT scans, where we can see a good gross total resection of the tumors. These are 2 cases of ependymomas also in children with their post-operative CT scan with a good tumor excision. This is one case of a cerebropontine angle meningioma, and this is the post-op CT scan. This is a typical case of a vestibular schwannoma, which has extended supratentorially into the left temporal lobe, and this is the post-operative image with a good excision. So regarding literature review, this is a case which was published in 2021, which says that the presence of preoperative hydrocephalus in patients with posterior facial tumors does not necessarily entail the need for permanent CSF diversion. This next study, which is done in children, says that less than 1/3 of the children with posterior facial tumors and associated hydrocephalus will require a permanent CSF diversion, in which hydrocephalus is mostly transient and will dissolve after tumor resection. This is the original article in which the posterior facial tumor resection was done without any CSF diversion procedure, and it says that the procedure without CSF diversion is safe and effective in treatment. So to conclude, routine preoperative CSF diversion is not necessary for the vast majority of patients with the posterior facial related hydrocephalus. A high index of suspicion and aggressive surveillance is required for the early identification and appropriate management of post-resection hydrocephalus. And future studies are also needed to address several unanswered questions pertaining to the management of this condition. So with this, I would like to conclude and thank you for your time.
Namaste everyone. First of all, I'd like to thank NESONCON for giving me this opportunity to present in one of my published articles. The title of my article is Role of Wall Shear Stress in an Intracranial Aneurysm Formation, or Systematic Review. So this was published in Journal of Surgery in 2022, and I've taken permission from the editor to present this article in this conference. And my co-authors are Himesh Lageju, Alok Dahal, Lokesh Shekhar Jaiswal, Shrestha Manandar, Sunit Chhetri, Rochana Acharya, Naveen Pokhrel, and Sagar Panthe. So before I start my topic proper, I'd like to introduce myself. I'm currently working as a primary care physician in Pastor, Nepal. I've graduated MBBS from BP Koirala Institute of Health Science, Dharan, in the year 2021. I've been affiliated to several neurosurgical organizations like Congress of Neurological Surgeons, World Congress of Neurosurgery, Abdul Raf University of Neurosurgery, Walter Reed Dandy Neuro Club of Nepal, Vanderbilt Global Neurosurgery Program, and I'm also enrolled in a research program at Harvard Medical School, Boston, USA, and I'm also the associate editor at European Journal of Medical Research, published by BMC, and I handle articles in the neurosurgery section. So before I start the topic proper, I'd like to share a story of a brave man. He was 85 years under regular medication of hypertension since years. He was a reformed smoker, and suddenly one day after dinner, he experienced the worst headache of his life, and followed by drooping of left eyelid after a few days. And he was rushed to Neuro Hospital, Biratnagar, where preliminary investigations were done, but the results were inconclusive, and he was advised to be done with CT angiogram, for which he was referred at Grandi Hospital, Kathmandu. And finally, he was diagnosed to have a massive posterior communicating artery aneurysm with oculomotor nerve palsy. So we seek the attention of Dr. Basanta Pant and the team at Annapurna Neuro Hospital, and was planned for the operation. Microsurgical clipping was done. However, after staying in the ICU for 3 months, he had a stroke and a complication of hemiplegia, for which he was bedridden for 6 years and finally passed away a few months ago. So this was the turning point of his life, and he is none other than my grandfather. So although he passed away, he gave me the he gave me an idea that I am born to become a neurosurgeon, and he gave me the potential to find the inner turmoil to become a neurosurgeon, and I dedicate this presentation to my late grandfather. So I also published his story in World Neurosurgery as a correspondence, which was titled as Letter to Editor. Could a patient's bedridden state of 6 years have been prevented and changed its fate? Should we emphasize the role of endovascular coiling of cerebral aneurysm in Nepal? So to introduce briefly about cerebral aneurysms, as we know, are the pouches of arterial wall formed by the thinning and weakening of internal elastic lamina and medial disruption.
the prevalence of unruptured cerebral aneurysm is reported to be about 2 to 5% in general population, and the aneurysms can be unique or multiple, and several risk factors have been attributed to the formation of growth or rupture of cerebral aneurysm, like the extreme of age, sex, smoking, high blood pressure, hypercholesterolemia, and atherosclerosis in general. And aneurysms also run in the family. And in most of the series, there is a female predominance of cerebral aneurysm ranging from the ratio 1:1 to 3:1. And most cerebral aneurysm usually remain clinically silent during their lifetime until they present with the devastating rupture of aneurysms, which can take the life of the patients in seconds. So although despite the uh, improvement in interventions, the cerebral aneurysm impose a high risk for mortality and morbidity. And the aneurysms have been classified into different types on the basis of etiology, on the basis of size, and on the basis of specific intracranial branch vessel. And the most recent classification, which is adopted worldwide, is based on the angio architecture. And the aneurysms are classified into fusiform aneurysms and saccular aneurysms, and they are further divided into simple or complex based on whether the aneurysms are present in the parent vessel or the branching vessels. So this is just a depiction of circle of Willis, which harbors the majority of cerebral aneurysms. And this is the research published in 2018 in World Neurosurgery, which shows that the frequency of cerebral aneurysms, that is single intracranial aneurysms in both males and females, is highest in ACOM, followed by the middle cerebral artery. So the physics of cerebral aneurysms is also worth discussing. So the physics include the geometry, which includes a maximum aneurysm size, aspect ratio, and size ratio. And the size ratio is only the statistical significant variable of physics of cerebral aneurysms. Similarly, flow pattern depends upon whether the aneurysm is sidewall or bifurcation aneurysm. And the wall shear stress, since my article is about the role of wall shear stress in an intracranial aneurysm formation, wall shear stress is simply the flow induced stress that is acted upon by the blood on the blood vessel or the endothelium of the blood vessel, and it is analogous to the viscous force that is imposed by a flowing liquid in a vessel or in a tube. So and in the recent literature, it is cited that wall shear stress has been linked with the formation, growth, and rupture of cerebral aneurysms. And aneurysms are managed with different techniques, such as the conservative management, microsurgical clipping, and endovascular management. And recently, stent-assisted endovascular coiling has been adopted for wide-necked and bifurcation aneurysms too. So the abstract of our study, this is the abstract of our study. As you can see, recent evidence suggests a link between hemodynamic factors and intracranial aneurysm inception. However, the role of wall shear stress is not clearly understood. So the aim of our study was to elucidate the role of wall shear stress in intracranial aneurysm formation. And we perform a review of literature by recreating articles from 2000 through 2019. PubMed and Google Scholar were used as a source of articles. And in the results, wall shear stress showed to have a significant role in the intracranial aneurysm inception. Other hemodynamic factors also played a role in the inception of cerebral aneurysms. The geometry and optimality principle, along with social factors like smoking, is also responsible for the formation of cerebral aneurysms. So at conclusion, wall shear stress plays a major role in the intracranial aneurysm formation. Gradient oscillatory number is the emerging hemodynamic factor for the inception of cerebral aneurysms. However, limited experiment in humans have resulted in inconclusive results. So this is the literature source that we adapted for this study. PubMed and Google Scholar, as I said already, were used as the source for searching articles. Different keywords like intracranial aneurysm with combination with computational fluid dynamics, hemodynamics, and wall shear stress were used. The various authors were used to screen the titles, abstract, and full text. And finally, the paper was approved by all the authors. So this is the literature source strategy, which was used to carry out the systematic review. And this is according to the Prisma guidelines. After removing duplicates, 1,584 articles were screened, and further 32 articles were screened for eligibility in the full text version. And finally, 17 articles were included in the review. So this is the summary of study data for risks of aneurysm formation. In fact, majority of the authors provided positive correlation of wall shear stress for the inception of cerebral aneurysm. However, two authors, that is Ford and Tanaka, found that there is no correlation between wall shear stress and the inception of cerebral aneurysms. So in a nutshell, I'd like to say that intracranial aneurysm formation is thought to have a complex origin. Hemodynamic factors play a crucial role in the process. A rise in local wall shear stress as well as other hemodynamic indicators such as gradient oscillatory number come into play. The geometry and curvature effects as well as hemodynamic and therapeutically important variables like smoking and hypertension all influence the development of intracranial aneurysms. So finally, I'd like to thank once again for NESONCON for providing me this opportunity to present as a talking poster in one of my published articles. And finally, I'd like to wish you all happy Dasai, happy festivals, and it's a great opportunity for me to connect with eminent people in the neurosurgical field from our country. Thank you very much.